Welcome to our latest and last of this season. Before I start, I want to ask anybody who has any ideas for next year, and I have a lot of them in my head, but we could always use some ideas for what we'd like to have next year. Let me know sometime this evening, or email me, and let me know what they are, because you can get almost anybody to speak about anything medical. And let me know, and we'll try to accommodate you. Okay, this is the last of this year's programs, and appropriately it deals with end-of-life issues. We have three wonderful speakers, and I'm not going to waste too much time speaking myself. Our first speaker is Yoel Lichtenstein, who is the Executive Director of the Margaret Tietz Rehab Center in Jamaica Estates. His topic for tonight is healthcare options as you age.
Thank you, Dr. Bright.
Please hold your questions for later, as usual, and write them down, and I'll get them out.
What is your topic again?
Healthcare options as you age. Okay. So again, my name is Yoel Lichtenstein, and I live in Muncie, New York, and work here in Queens. I've been at Margaret Tietz for about a year. I've been in healthcare administration for over 20 years. And thank you so much for having me here. Just wanted to acknowledge my Aunt Charlotte is in the audience. That was a nice surprise. Okay, so the topic is healthcare options as you age. And just a little disclaimer, per the Centers for Medicare and Medicaid Services and New York State Department of Health regulations, the information presented herein is strictly for educational purposes. We're not promoting any product or service. I'm just providing information. And also, it's broad stroke. Individual cases may vary. Okay. So.
You think that really gets you off the hook with the attorneys, huh?
Probably. Okay, so just a little bit of a background in terms of trends in the United States. 13% of the United States population currently is over the age of 65. And it is the largest growing segment of the population, so that it's projected by 2040, 22% of Americans will be over the age of 65. And what that last line on the bottom means, rising proportion of old, as a result of advances in medical technologies and also education. People are taking better care of themselves. Generally speaking, people are living longer. So whereas 20, 30, 40 years ago, there were not many 90-year-olds around, that is not the case now, and it will continue in that direction, where there will be a rising proportion of people who are in their 80s and 90s and beyond. At Margaret Tietz, where I work, we have several centenarians, is that what they're called? So it's quite an interesting phenomenon. Okay. As people age, there is an increased risk of getting a whole bunch of really bad things. So if you could just close your eyes and picture on this screen, there's a number of things there. There's emphysema, depression, arthritis, thyroid problems, Parkinson's disease, incontinence.
We're getting him, Yoel.
Okay. Pressure ulcers, heart attacks, constipation, dementia, osteoporosis, increased risk of falls, and strokes. So a whole bunch of stuff that there's an increased risk for as people age. Unfortunately, it's been my experience that some people have a whole portion of the screen all in one. Unfortunately, somebody may have Parkinson's and a heart condition and dementia. So the good news is some of it is actually preventable, or one could reduce the risk of getting this really bad stuff that you can't see right now. So proper diet, exercise, not smoking, things like that. Healthy lifestyle could reduce the risk of getting some of these diseases or syndromes.
It says FN and F7.
You don't know where he went.
I know that he was looking for a power cord. I don't know if he got that in the end.
That's probably why it was in. That's probably where he went.
Yeah, that's probably it. All right. We'll continue. Okay. So there actually is a. Okay, so we'll wait a second. Just out of curiosity, are anybody in the audience a health professional? Okay, doctor, nurse, OT, PT.
I'm a speech pathologist, but now I'm a school administrator.
Okay, and
I'm a nurse.
nurse, RN?
Yeah, I'm in Center at Columbia.
Columbia. Okay, great. And while we're waiting, there's a young lady in the back in turquoise, and that's Linda Spiegel, and she's the Director of Public Relations at Margaret's. And there's plenty of pens and plenty of pads, so take some home, share with your friends and family. A little bit about Margaret's, since we're just waiting for this. Margaret's is a 200-bed skilled nursing facility, not-for-profit. It is
Here you go.
located here in Jamaica Estates.
Sorry about that.
Okay, no problem. And we have a variety of amenities for the observant Jewish population. We're strictly kosher under the Van. We have a Shabbos apartment that's a block away, a Shabbos elevator, Shabbos entrance, full-time rabbi. We have a shul on the premises, daily minyanim, Shabbos and mincha, except for Fridays. We have services on Shabbos and Yantiv. It really is the place if somebody is looking for a Jewish environment, in addition to great care. Okay. Okay, so I just wanted to kind of break it down. There are quite a number of services that are available for people as they get older. Some of them are provided outside the home, and that is the top level over here, and some are provided inside the home. You can see also that there's quite a bit of interplay. Somebody might, let's say this is Mrs. Goldstein, she's living at home somewhat independently, she breaks her hip, she goes to the hospital, she gets stabilized, she may go to a Hearst nursing home, she may go home and get some skilled home care, and at the same time she may also be part of an insurance program, and we're going to talk about some of these. So there's quite a bit of interplay between the home-based services on the bottom and the ones that are provided in institutions. What I decided to do tonight is just spend a few minutes talking about 5 different care settings or care models. So the top 3 are community-based, that's Certified Home Health Care Program, or CHA, Managed Medicaid Long-Term Care Program, that's MMLTC, and a program for all-inclusive, it should say care for the elderly PACE program. And then finally we'll talk about skilled nursing short-term and skilled nursing long-term. Okay, so what is a CHA? Typically, if somebody is in the hospital because of an acute spell of illness, a common example would be a stroke. Somebody had a heart attack, let's say they broke their hip and had a hip replacement. They are going to be discharged home at some point, either from the hospital or if they go to a skilled nursing facility and then go home. Typically they will require some level of service when they go home. So a certified home health agency will provide that kind of service. So typically it will be a home health aide. Sometimes, let's say there's a wound that the person has and it needs a dressing change, a nurse will come in. Sometimes there'll be, like what happened to my mother-in-law in Baltimore. She had back surgery and then she came home, and a certified home health agency provided therapists that came to the home to help her regain her function to walk. So that is the typical profile of a recipient of a CHA services. Also, you could interrupt at any point with questions or comments, so you really don't have to wait till the end. So. The next thing I wanted to talk about is Medicaid managed long-term care. Now this is an interesting thing. The Medicaid budget in New York State was things were going through the roof. And Governor Cuomo recognized that Medicaid would be bankrupt unless something significant was done. So what he did is he did some level of really what was sweeping reform, consolidated and phased out a number of programs that are provided for people who are living in the community who require extensive care. What we're talking about here are people who are safe enough to live at home, but require skilled level care. And by that I mean, were it not for their ability to stay home, they would be in a nursing home. So it could be that they have dementia, it could be that they need assistance with a variety of things, let's say dressing or feeding themselves or bathing themselves. So they would be in a nursing home were it not for their choice to live at home and their ability to do so safely. So there were a whole bunch of these programs that existed that were phased out. What ended up happening is there were anybody who qualified to be in that kind of a program, it was mandatory that they enroll in a managed Medicaid program. So now we're talking about people who qualified financially for Medicaid, were sick enough to be in a nursing home, but were safe enough to live at home. They all had to enroll in a managed Medicaid program, and that's the MLTC, Medicaid Managed Long-Term Care. There are 12 such programs that are just straight insurance products, and then there are a couple of programs that have a combination of insurance and provider, and we're going to talk about just two of them. The first is the MLTC. The way that works is, if somebody has Medicaid and they are very sick enough that they require long-term services at home, Medicaid will pay for anything that normally Medicaid would pay for. So that means they're not going to pay for doctor's visits, hospitalizations, medications, because that's typically paid for by Medicare or private insurance. So nursing, social work, care management, aids, medical transportation, rehabilitation. The bottom line is, I was thinking about this when I was preparing this presentation, there's a lot of information to absorb, but what I'd like you to take away from this is, God forbid, if you know of someone who requires this kind of service, because typically what happens is, there's an acute spell of illness, people are not prepared for what happens next, because let's say somebody, God forbid, has a stroke, now they're going home, and maybe it's your friend or your just someone else that you're related to. You'll want to know that there are options available, so at least ask the questions. You can remember, I remember there was this guy from Margaret Tietz that spoke about Medicaid managed care. Speak to the social worker in the hospital, and then you can get more information about it. You can certainly also call us at Margaret Tietz, and we could help guide you to probably the best resources for you. So that's Medicaid managed long-term care. And the last program that I wanted to talk about that is community-based is really an outstanding program. It's called Program for All-Inclusive Care for the Elderly, or PACE. Now Centerlight, which is the parent corporation of Margaret Tietz, really was a pioneer in this realm. People who are in the PACE program, it is truly an all-inclusive program. That means that anything that Medicaid or Medicare would pay for, which really is all healthcare services, are included in this program. And it really is at no cost to the person who's involved. It's a great program because in addition to having all of the services paid for, it's very well coordinated, and there are PACE centers that people can actually go to for socialization, if they want recreational activities. But on those same sites are the doctors, the nurses, the social workers, the nutritionists. At times there are specialists that are there as well, vision, dental, podiatry, audiology. It's a very well coordinated program and very, very successful. Actually, there are a few of the centers right here in Queens. There's one in Ridgewood, there's one in Flushing, there's one in Jamaica, actually there's one in Far Rockaway also. It's one of the most impressive programs that I've ever seen in that it really truly takes care of all the healthcare needs. Yeah.
And financially,
So the person would have to have Medicare at the very least, and if they have Medicaid as well, that would help. But I'm pretty sure if they just have Medicare, you would qualify for it. It really is a great program. It's been very, very successful. Actually, it's one of the most commonsensical programs that I've seen in my career because it just is, everything is very well coordinated in one spot. There's a doctor that you're always seeing. It's the same doctor who knows you. And that person is talking to the other healthcare professionals. So it really is something worth looking into. And if you're interested, you can look on the web and look up PACE. You can go to Centerlight's website and you'll get information about our PACE program.
What's the limitation in time? For how long do you
This is for life.
extend it?
Because actually what ends up happening, you can disenroll at any point, but if somebody requires hospitalization, that's also included. Because what's happening really is, instead of Medicare paying the hospital directly for the services for the people enrolled in this program, they're paying a certain amount of money every single month to the PACE program. And then the PACE program figures out how to spend the money the most wise way. And there's a lot of flexibility in this program. The classic example is, if somebody is living at home and it's very, very hot, and the nurse or the healthcare team realizes that this person's at risk for heat stroke, they can use the Medicare dollars to buy an air conditioner for the person. So there's a lot of flexibility in this program. It really is quite impressive.
So it's better to stay at home, and then for the day you can go to this.
Absolutely, yeah.
Do
And
you
going
go
there
5
is
days a week?
I actually think it's 7 days a week.
7 days.
How does long-term care kick in?
That's a great question. Okay. All right, so that's actually the next slide. So there are times, the basic fundamental here is, if somebody could stay home in the community, we want them to do that as long as is safe. However, sometimes it's just not safe. So take, for example, there's a couple living together, someone independently, one of them gets dementia, it starts to progress pretty quickly, and now what? An elderly spouse might be at a disadvantage trying to take care of someone who constantly is wandering. Somebody might be at risk for falls. If for whatever reason it's just not a safe environment, or there isn't the proper support from family or neighbors or friends, nursing home may be an option. But before we get to that, I just want to talk about short-term nursing home stay. The examples that I gave before, if somebody had a stroke, cardiac event, had orthopedic surgery, once the hospitals are going to stop getting paid after a certain amount of time. And they're going to want to discharge somewhere, but it's often not safe to discharge home. And that's the case that a skilled nursing facility, short-term rehab center, Margaret Tietz is one of them, that becomes an option. And typically Medicare will pay for that stay. Medicare will pay usually up to 100 days. Although the average length of stay for somebody who is in a short-term skilled nursing facility like Margaret Tietz is, at Margaret Tietz it's actually pretty low, it's 24 days. If somebody has a managed Medicare insurer, it's actually less, it's about 14 days, because the managed care companies are much more aggressive in terms of getting people discharged home faster. So that's the option for skilled nursing.
Does long-term care have limitations also to stay, or regardless how long it takes?
Well, that's a very good question. And actually, it's the next slide. So the final option for institutional care is long-term care, and that's if somebody has a need for 24-hour supervision, and really everything is taken care of. It's dental services, it's optometry, everything is basically covered. In terms of the ability to stay, it really has to do with the ability to pay. So if somebody is covered by Medicaid, it's usually guaranteed that there's not going to be a problem. They can stay as long as, they can stay. But if somebody is there for private pay, it depends on how long the resources can last, in which case they would just apply for Medicaid, and there really, historically, has not been a limit. Because you can't get discharged.
long-term care is no limitation, right? It's for as long as it's needed, right?
Right, right. Well, under Medicaid. Medicare, which is the short term, would be a limit of up to 100
A
days.
separate payment to long-term care agency insurance.
So that's a good question. So some people buy insurance policies, long-term care insurance policies, and it's debatable whether or not that is a good thing to do. I know my parents did it. There's both sides of the argument. It's very rare that we get somebody in the nursing home who has a private insurance because they're very costly policies.
I have it for 18 years.
Yeah, so then you would be in better position than others.
Better position for what?
A better position than others
Yeah,
to
but
get.
she's got to stay in a nursing home, so the long-term insurance should pay for it.
It depends on how the policy is written. Most long-term policies are written exactly for that purpose to cover. Yeah. Okay. Just wanted to mention just a couple of small.
So could you discuss after you finish what to look for in your long-term insurance?
I'd be happy to do that after everybody speaks because I think I'm already going into overtime.
Okay.
But I'm happy to talk to you, absolutely. I'd be happy to come back and talk about that as a separate topic. That would be fine. I just wanted to mention very briefly that within the nursing home, long-term care, there's also the possibility of hospice care, and I really wanted to mention that as the other end of the spectrum. Hospice care is for somebody who has a terminal diagnosis, usually has only 6 months to live. And it's usually provided at home. If somebody's living in a nursing home, that is their home. So it's called residential hospice. And in addition to whatever is provided by the nursing home, the hospice agency also provides additional staff and resources. What we offer at Margateets is something somewhat unique. There's actually an inpatient hospice unit, and what that is geared towards is for people who are truly at the end of life. We have people who come there for a few hours to a few days. And although many of the resources are given to and support are given to the patients themselves, particularly in terms of pain management, palliative care, a lot of our resources and support are given to the family members because they're the ones who are, unfortunately, in these cases, more alert and aware of what's going on and just need that support to help them through the process.
I didn't understand. I thought hospice was, if the doctor says you have 6 months to live, then you go into a nursing home until you pass on.
Right, so the way hospice works, actually, there are various models in hospice. The most common one is that people are living at home and the services come to them. Because it's just generally, for a variety of reasons, better to be at home. There are cases that we've had where, unfortunately, we had a young woman, a young mother, and it just was a burden on the family. It was just very tragic for the kids to be around a dying mother. So she opted, and the family opted to have her come to the nursing home. But it's always a better option if it's safe and practical for other reasons to have the person stay at home. Although it could be provided in a nursing home.
Is there a lot of slides left to show?
We're done.
Okay.
Elaborate a little bit on the charges so people have an idea what the charges are.
Okay, well, charges are, nursing homes are expensive. I mean, it can range from $3,000 to $10,000 a month.
$3,000
Right.
is enough.
Yeah, $3,000 is a bargain. That would probably be in like Schenectady. And then there's some other options. Nobody's here from Schenectady. But there are other options. There's independent living, assisted living, or just time doesn't permit to get into it.
Could I ask you a question?
Yeah.
Now this cavalry that they,
Calvary.
now, are you, these people that go into cavalry, they stay there for 4 or 5 months, don't they?
That's a hospice or a hospital?
It's a hospice.
It's a hospital, yeah. Actually, maybe Rabbi King can speak to that better than I.
I think Calvary is a little different than other hospices. Calvary in the Bronx is a hospital, if I'm not mistaken.
Yeah, I'm not informed
It's
that
a
I have to
hospice.
speak of that.
So my grandmother passed away then.
It's a hospice,
My
okay.
grandmother was passed.
So I was saying there are various options for hospice. One is living at home and getting the services, another is being in a nursing home and getting the services. Then there are hospice centers
Right.
where somebody can
Oh,
live.
so that's what you're saying there.
And I'm happy to, yeah.
What happens if you go past the 6 months and you're still alive?
That's a great question.
Don't ask that question.
Some people graduate from hospice. We've had people shift off of residential hospice and become just regular nursing home residents. And then sometimes they go back again.
All you need is a reasonable diagnosis of 6 months left. It's not a drop dead date.
Yeah, yeah. And we've had people go on and
I
on.
visualize them cutting off all the fun.
That's a good one. Yeah. Okay, I'm sorry if I went into overtime. Thank you again.
Rabbi David Keene is the chaplain at New York Hospital Queens. And he will be speaking about the role of the chaplain in the hospital.
Okay.
And how he can help you.
Good afternoon. Good evening. Thank you, Dr. Bright, Rabbi Rosenberg, Dr. Finkett, and Yoel. It's a pleasure to be on a panel with both of you. So I'm going to talk a little bit about the role of a chaplain, particularly maybe on some level of a Jewish chaplain in a hospital. And perhaps we could talk about, in specific, the role of a chaplain, a Jewish chaplain, on end-of-life decision-making and end-of-life issues. Dr. Finkett will talk about the role of an ethicist in decision-making. So the first thing I'd like to talk about, and that's and I have some handouts if people want to take them, is what's the definition of the chaplain? So a chaplain is somebody who creates sacred space for people of all faiths and varied cultures during stressful transitional moments, creating meaning, hope, connection, and comfort by using their own source, inner source of strength, their inner source.
Handouts.
What?
Where are the handouts?
Their inner source.
Where are the handouts?
Oh, they're on the Bima. By people using their inner source of strength, their inner resources. Anybody want to perhaps guess what the most important piece, the most important line in that definition is? If you don't know, I'll tell you.
Do you have a shawl in the hospital?
I'll get to all those questions perhaps at the end. The most important line perhaps as a definition, in that definition, is using people's own resources. And that could be the patient's own resources, the family's own resources. That could be their own religious tradition, their own religious guide, their rabbi, their minister, their priest. It could be storytelling or just being present with somebody. It could be praying or singing psalms. Whatever gives the person, the patient, from themselves. Chaplains don't push their own beliefs onto patients. Sometimes we educate, and sometimes we inform, but ultimately, it's the patient's and family's own decisions from their own traditions and their own value systems that frame their decision-making. Why would somebody call a chaplain? There's some reasons, and it's the third page or the second page after the definition. Some reasons, not a total list, is that patient or family is having a difficult time with the stress of the hospitalization. A patient or family member might be feeling anxious or angry or sad or depressed, might be a good reason to call a chaplain. A patient or family for that matter might have just received a very difficult diagnosis, a prognosis, might be a good time for it to have a chaplaincy intervention. A patient or a family might be in the hospital during a particularly momentous occasion in their family's life, whether it's a wedding or a bar mitzvah or even, God forbid, a funeral. And nowadays with technology, sometimes we could actually bring that simcha, bring that celebration, that wedding or bar mitzvah to the patient's bedside using Skype or tablets or any one of a number of varied things that they could actually be in the hospital bed and watch and actually feel like they're part of there. It's not like being there, and it certainly may not even be second best, but it's better than not having any kind of participation. If a patient or family member needs some sort of religious ritual, whether it's Sabbath candles, and I always say when somebody asks for Sabbath candles on a Friday evening or before a holiday, it's not just Sabbath candles. It's really it's the connection that they have to home. It's the connection that they have to their religious life. And sometimes somebody's been lighting candles their whole lives, could be 70 or 80 years, and for them not to miss it, just because they're in the hospital, can be a very, very emotional and spiritually connecting thing, not more than just the actual ritual. And sometimes people ask for things like shofar blowing or Megillah. These things are also, or Seder at the hospital. These things are also more than just the actual technical ritual for our patients. It's a spiritual connection to their history and to their theology and to their wellness.
How about non-Jewish patients? Could you get also?
What was that?
Non-Jews, I don't know.
They whatever their own particular rituals might be, that could be a connection. And sometimes when you're sick in the hospital, that can be a very important connection to happen. Very important part of their healing process, if you will, their hospital stay. It might be important to call a chaplain if you're having an ethical or a difficult decision-making process, to be able to call the chaplain in and flesh it through between family members and the medical staff, or just to hear both sides of the argument, or both sides of what the options are, or what the different options are. That's an important time to call a chaplain. Sometimes it might be a good thing to call a chaplain if a family member is going through a code. A code is when somebody gets very sick and their heart stops, God forbid, and everybody comes running in to really restart the heart. And there are doctors and nurses and PAs and a lot of people in the room tending to the patients. And what usually happens is the family member is outside in the hall by themselves, very scared, very anxious. And to have a chaplaincy intervention, just to have somebody stand in the hall with that family member, can be a very, very powerful time.
Excuse me, all hospitals have kosher kitchens, so they get
No,
from
most
outside-
don't, and
outside
we can get to that later. You could ask me that in a few minutes. Let me finish the presentation so we could actually talk about what we're here for, and then you could ask me those not personal questions, but you could ask me those questions. And sometimes it's important to call a chaplain if you have a patient or a family member or somebody in the community that might be lonely. We all know people who are in the hospital, and many, Baruch Hashem, thank God, many of our families and friends and people we know have large families, uncles, aunts, cousins, sons, daughters, large extended families. But for every family that has a large support system, there are probably 10 people in the hospital that have nobody, that are either alienated from their family or just that have nobody to talk to and have nobody to be with. And to have a chaplain or anybody for that matter, because home volunteer, we see some of them here today, to come in and spend some time, whether it's a little time, 5 minutes, or whether it's an hour with them, that can be a very important part of the healing. And also, many times our medical staff they're so busy. They really truly are so busy taking care of so many different patients. And there might be a particular patient who just needs to talk. And the nurse or the doctor just doesn't have that time to spend talking to that one particular patient because they have 10 others that they need to see. A chaplain's a good person to call for that particular person. So those are some of the reasons why one might call a chaplain. So I'm going to skip over the bullet point that says case study, and actually, I'm going to talk about that now, and then maybe Dr. Fink can talk some more about it either later or we can talk together about it. The case study, I'm not going to go through the whole thing, but the basic idea of this particular case study and how I, as the chaplain, as a Jewish chaplain, was involved, was that there was somebody, she came to the emergency room, she was home, she was a vibrant 88-year-old, and she was home, her son was visiting her on a Sunday morning, as he often did on Sunday mornings, and he went out to get the paper. He comes back, and unfortunately, she's not very responsive. They call Hatzalah. Hatzalah revives her and brings her to the emergency room, and they bring her to the ICU. And she's very, very sick throughout the week. Now, this particular lady had basically two wishes that she expressed to her son. One wish was she always wanted to do everything according to Jewish law. According to halacha, she wanted everything to be done, every decision to be made according to halacha, according to Jewish law. That was one wish she expressed to her son. The other wish she expressed to her son was that she didn't want to live in on machines, and she didn't want to be in a vegetative, quote unquote, vegetative state, whatever that means, and she didn't want to be a burden to her family. So about a week into her hospitalization, the palliative care team and the medical team wanted to have a conversation with her, with the family, to see what the goals of care should be, what the next steps should be. She was in the ICU, more or less steady. Again, if you read the case study, there are some fluctuations, but for more or less steady throughout the week. And they wanted to know what the goals of care, what the next steps were. And again, this crossroads, the son was at a crossroads. He wanted to follow halacha, but he also wanted to follow his mother's wishes. Both very powerful pulls in this person's life. You're a kid, and not following what your parents say sometimes is easier. But 70 years down the road, you want to follow. It's a very big pull for children to do exactly what their parents are asking them to, or have asked them to do. So they called a consultation, a family meeting, something that chaplains are involved with daily. The medical team and the palliative care team was there, and the chaplain. That was me. I was there. Also at this family, and the family was there. The son, the daughter, and the daughter-in-law were all there. The family, the medical team, chaplain. On the phone, in the middle of the table, on the speakerphone, was the family's rabbi. They were taking guidance from the family's rabbi, and the son explained to the best of his ability, and he was actually incredibly accurate, as to what the prognosis was and what the situation was for his mother and what the prognosis was. And at this time, his mother was on a respirator ventilator, which was helping her breathe. The medical team thought, and according to Jewish law, as Dr. Peek will tell you, according to Jewish law, if you're on a ventilator and if you're taken off the ventilator, and you're unable to breathe on your own and you pass away with that, that's not something that we as Orthodox Jews necessarily do. But the medical team did say that they thought that if they took her off the machine, she would probably be able to breathe a little bit on her own. So the family rabbi gave certain guidelines, and me, as a chaplain, who has been in these meetings before, perhaps maybe in these meetings before, was able to ask and drill down the appropriate questions with the family rabbi, with the family, with the medical team. And at the end of about an hour of back and forth, not really negotiations, but understanding, defining and redefining what the halacha is, defining and redefining what the rabbi meant, defining and redefining what each person on the care team thought the outcomes might be. The family came to a very reasonable, understandable decision, and the decision was that they would try to wean her, and she passed away. They would try to wean her, and she did breathe on her own for a bit, and then she passed away a little bit after that. I think the important thing here to understand the role of the Jewish chaplain, wasn't to give what I thought was the appropriate thing to do. It was to sort of help facilitate the family, the medical team, and the rabbi to get everybody on the same page, so that the family's values were able to be respected, so that the son was able to both respect what his mother wanted, meaning follow halacha, what the rabbi guided him to do, but at the same time not be a burden and not have his mother be a burden to live on machines for a very long time. Not always a simple thing to do, not always a possible thing to do, but in this particular situation it was. Would I have decided things differently? I don't know. I think, again, my role is to sort of facilitate things with different rabbis, and with another rabbi, with another family, perhaps even with another doctor or another medical team, the decision may have been a different one. But to be able to walk away and help a family walk down the path or walk down the journey of those end-of-life decisions, which are struggles, and they should be struggles, that they could be comfortable as somebody could be with these decisions, that's a really holy and special place to be, and a very holy and special place to facilitate. It's more than just giving out Shabbos candy. So that was the case study, and we could talk more about that later, and perhaps have questions about that. The last few things are about end of life and what a chaplain would do would be present. Sometimes when there's families when there's somebody that's passing away, there's almost nothing you could say. There's nothing good or bad that you could say. Just be there with them. Be there with your family member, and as a chaplain, be there with the family members who are with their family member. And I always encourage family members to try to talk to the person who's passing away, to try to talk to the person who's at the end of life. And they say, do they hear me? And I always encourage families, maybe they do, maybe they don't. But it's just as important, if not much more important, for you to say all the things that you need to say. I love you, Mom. I love you, Dad. Thank you. It's very important. Or even conversely, you know what? I've been meaning to say this my whole life. You weren't very nice to me or very good to me. That's important for the family to be able to potentially say and be there with their family member. Those are opportunities they may not have in a few days or a few weeks. Ritual. I would always encourage families to do whatever ritual in their life, in their tradition, for end of life, whether it's getting what they call the last rites or anointing, or for us, for Jewish people, what we call vidoy, and sometimes it's a longer version of vidoy, and sometimes it's a shorter version of vidoy. And if we're able to do that with a family member or with somebody, that can be very comforting at the end. And I would educate people, again, people's patients and families' decisions always come from their own values and what their traditions are. But I would educate them on what to do for, and what's appropriate for a Jewish funeral and what's not appropriate for a Jewish funeral. And I would facilitate with them whatever arrangements they need to make. Sometimes families, even families who are well connected religiously, people who are in their 50s or 60s have never done this before because they've never needed to, thankfully. So I would just, help them through that process, help them through that hospital process of what's going to happen after somebody passes away. Those are all things that I try to do towards the end of life. Again, thank you for your time, and again, it's been a tremendous honor and privilege to share a panel with you all, and certainly in Dr. Fink, who I've known a very long time. And now I'm going to ask Dr. Fink to talk about the ethicist's role in end-of-life issues, and perhaps afterwards we could all talk about questions, and whether about the case study, or whether about what I do, or whether it be what I do in the hospital, or other things that I do. Thank you.
Thank you very, very much. Before I introduce Dr. Fink, I'm going to tell a little chaplain story myself. This is a true story. It happened to me when I was a young attending at Weiler many years ago, with an elderly Italian woman whom I call Mrs. Russo, not her real name. One morning, I came to see her on rounds very early in the morning, as I was wont to do. And she was facing the window, and I came in the door. And at the door, I met the Catholic chaplain, who was about to come in and to give her communion, which he did every day with her and many of his other patients. I knew him well. And I said, Father, you go in first because, I'll spend more time. He walks into the room and he says, good morning, Mrs. Russo. And again, she's facing away from him. And she screams out, get out of here. They took my blood already. Get me some breakfast. Don't bother me. And he went over to her and he said, you know who I am? And she, oh my God, she said, I'm sorry. But that's so some of the travails of chaplains, you know, being misidentified at times.
We're actually one of the only people in the hospital who people can say no to. And it's powerful, and it gives people their dignity back if they're able to say, no, thank you very much, I don't want to visit from you. They can't say no to the doctors or nurses or the technicians who come to take their blood, but they can't say no to us. And that's not a personal offense, or at least I try not to take it as a personal offense.
How often does that happen?
It can happen. It happens almost all the time, especially for our chaplains who visit people on just rounds, and they may come across somebody who may not be up for a visit. So it could happen almost daily. If people request me, then generally they don't say no. But if we're just doing rounds, people can say no to our chaplains all the time, and that's okay.
What if they're angry?
What if they're angry?
What if they're angry at God? I'm just kind of curious. If they're angry at God.
What if they're angry at God? Could we?
A little weight on that one.
We could. I mean, I have an answer for that, but I think Dr. Fink's been here, so let's.
Dr. Simon Fink is a graduate of NYU Medical School, did a surgical residency there, has been on the staff of New York Hospital Queens, back in the good old days when he and I were on the staff, and it was called Booth Memorial. Still on the staff, still operating, and some of my patients are alive and will testify to that. For several years, he has been the hospital ethicist, and I'd like to introduce him to you right now, Dr. Fink. Thank you.
Do you have Pico-Collium people coming from?
Yes, we do.
Pico-Collium people.
Well, there is Baker Colum, but they're not here tonight.
I am.
Oh, she is, actually. We have one.
No.
Good evening. I'm glad to speak with you. I'm going to be relatively pragmatic. I'm going to talk a little bit about end of life, people who are dying, and what's going on and what you should be thinking about, mostly from an ethical point of view. There are many, many points of view. Obviously, religious, cultural, legislative, physician, family. So my piece is to try to just give you a flavor about what's going on and what you should be thinking about. I'm going to go from the macroscopic down to a small area. I want to give you a little bit of an introduction, a little bit of background about how bioethics came into the common position that it's in nowadays. Before World War II, bioethics was something that professors talked about at Yale and Harvard. It never impacted very much on the day-to-day life of most of us. But then three rather dramatic things happened that required that bioethics be part of the culture, part of the conversation. First was World War II, when doctors, Nazi doctors, committed the worst atrocities that any human beings have ever done. These are doctors. So there's medicine with all its alleged morals, rights, ethics, and so on, and physicians are engaging in this. And then in this country, we had two horrific moral lapses, both done by good groups of good people. One was the syphilis experiment, which started in the 30s, in the era before penicillin. And it was mostly poor blacks in the South, who were males, who were enrolled in this program. And then there wasn't much to do except to provide supportive care. But then penicillin showed up. And some genius decided that it was perfectly okay to withhold penicillin so as not to change the course of what was going on here until someone, read the Riot Act. So they actually allowed people to continue to suffer with syphilis rather than give them penicillin. The second one is from my own medical school, a rather prominent pediatrician named Saul Krugman, who discovered a great deal about hepatitis. He virtually invented all the ideas we had about infectious hepatitis. And how did he do it? He showed up at Willowbrook, which was a facility for developing disabled children. There was virtually no system of hygiene, and so virtually 100% of the kids would get hepatitis. So he thought it was reasonable to try to figure out how hepatitis was being transmitted, and so on and so on. And he actually, during part of these experiments, actually experimented with transmitting hepatitis because, heck, everybody got it anyway, we may as well learn something. that has a very, very shaky set of moral grounds. And in that background, then we begin to see the reasoning why we need to have a very firm foot in medical care, namely medical ethics. I'm just going to give you 4 simple principles that we find important in bioethics. One is autonomy, and some feel we place too much emphasis on autonomy in this country. Autonomy being the right for you to make your own decisions, as long as you have capacity. So that's a primary directive. Beneficence, that is that when we interact with people, certainly in medicine and other areas, that our job is to do good. Non-malfeasance, that is we shouldn't do anything bad. And the last one of the 4 major principles is justice. When we engage in these kinds of activities, we need to be sure that it's done in an equitable fashion. So the first real cut of this is, at the end of life, what is the nature of care that should be provided, and what's the quantity of the care that should be provided? So we're talking often of elderly patients, debilitated patients, patients who can't speak for themselves, patients who we don't know what they really want. And the thing that we have to decide is who is going to speak for the patient and what kind of decisions are they going to make. So prior to World War II and this experience with the Nazi doctors and others, it was very paternalistic. There was no such thing as an informed consent. If you had gallbladder problems, the doctor would come in the morning and say, "We're taking out your gallbladder today," and you said, "Yes, yes, sir," and off you went to the OR. So there was no informed consent. Also, what do we do with patients in the group that we talked about earlier, where over the age of 85, which is not a small number of people, unfortunately, or fortunately, over half of them have some real dementia. And even those who are in relatively good shape have a lot of disabilities in how they function mentally. And so we need to decide how we're going to help them make decisions. And the best way is obviously to have an appointed surrogate. And if you're going to appoint a surrogate, which is another point you ought to write down, I see some of you taking notes, you need to really discuss in great detail what you want. Because what's right for me may be totally wrong for you. There are patients who say, for example, I don't care what it is, I do not want to be in a respirator. If I need to be a respirator, thank you very much. Give me something to make me comfortable, have my family around me, make sure I don't have air hunger, meaning having trouble breathing and feeling miserable, but I don't want to be on a machine. And as far as I understand it, even in Orthodox point of view, you are not required to take care that you find burdensome. I'll leave that to the rabbi to answer. And so one of the things you need to do with patients in end-of-life situations and their surrogates is you need to discuss risk, benefits, alternatives. Now, what about the issue of withdrawing or withholding burdensome care? Someone has had a terrible event, they're on a respirator, they're on blood pressure medication, they have a tube in the bladder, they're on medications to maintain their blood pressure, they're being fed through a tube, they're getting x-rays, shots, up all night, never getting a minute's peace, they're sedated. When is enough enough? Well, the first thing is there a difference between withdrawing care, so someone's on machines with all this stuff and you stop it, or is it the same as withholding care? Someone needs the care and you elect not to do it. Well, intuitively, if I went around the room, virtually everybody would say they're very, very different. But if you think about it long enough and hard enough, they're really very much the same. They're basically not providing care that's either required to achieve a certain expected outcome or to save life. So they're very similar. So if you're in a circumstance where you believe that your loved one does not need this care, you need to be comfortable, if you think that's what you want, to withdraw that care. Now, one of the interesting things is that some of these problems can be anticipated. You can talk about them. So you have somebody who has high blood pressure and some kidney disease, and the doctor's telling you they're progressing to renal failure. You know that in this next 6 months, year, whatever, they're going to need dialysis. Now's the time to discuss, what do you want to do if you need dialysis but you can't make a decision because you don't have capacity? Patient who has chronic lung disease, who's getting to the point that they may not be able to breathe on their own, they may need to be on a respirator or have a tracheostomy, a tube in the neck here to breathe. Do you want that? You don't want that. Now the other thing to be aware of is what they say when they don't need it may not be the same as when they need it. Don't you dare put me on a breathing machine. Don't you dare. I'll come back and haunt you. Don't you dare do it. Don't you dare do it. I can't breathe. Put me on the machine. So while you can have some idea what someone wants, many of us really don't understand what it is we're turning down. And so you need to be adaptable and be willing to change what you do based upon what's going on. Now, one of the things about being a surrogate, that is, if you're going to be a decision maker for somebody, and one of the things that's very much misunderstood, while a surrogate does have some leeway about making decisions about what kind of care they're going to authorize, they are really honor bound, I use that word very advisedly, to follow what the patient wants. So if you can't do that, you should not be the surrogate. Your job as a surrogate is not, now I'm the decision maker, I'm going to make the decisions that I think are appropriate. So for example, if your loved one has said, under no circumstances do I want to be on a respirator, even if I'm going to get off it, now they lose capacity, you can or should not, as a surrogate, decide, well, we're going to put her on the respirator just for a while to see what happens. So you have to be comfortable with, and it also requires that you have a nice, frank conversation, and a lot of people, families, are not happy about having such conversations prior to the actual events. Good surgeon, I can't even turn the page, right? And again, I want to emphasize, I wrote it a second time, is that withdrawing and withholding care are the same. They both end up with needed care in terms of outcome not being provided. And what about when the care that is not being provided is literally life-saving? What about the circumstance when you have a patient who may or may not have a heart stoppage and need to have their heart pumped? Is it okay to discuss that in advance? Yeah. Is it okay not to do it? Yeah. Are there certain religions and faiths and people who say, no, that care must be provided? Yes. Are you as a doctor required to provide it? No. But you're required, if you know that care is going to want to be provided, you're required to let the people know in advance that you will not do it and they need to get another position. So you can't be compelled to act against your own sense of right and wrong, but neither can you act as a judge to say, this care should not be provided, this care should be provided, and unless you do it the way I'm telling you, I'm going to do it the way I want to do it. That's not allowed. The patient has their autonomy and needs to direct their physician and their family about how they want the care rendered. One thing we get often asked about is euthanasia and physician-assisted suicide. I think I'm not going out on a limb when I say from medicine point of view, nursing, law, ethics, morality, in this country for sure, no form of physician-assisted suicide or euthanasia is considered appropriate. Now, where the problems come in is in circumstances where life is truly a burden. So there are people with terminal cancer who are riddled with pain, who are begging for their lives to be over, where this really gets to be a big problem. But we still pretty much feel that we cannot assist patients in ending their own lives. And one of the examples is the wink wink, oh, you're having a lot of pain, let me write you a prescription for 60 Demerol. But don't take them all at once, because if you take them all at once, you may stop breathing. So remember, don't take them all at once, because your breathing may stop. That's not okay. That's been done, been described, and patients do it on their own without even talking to physicians. I'm not suggesting that patients should not get the proper medication to relieve their suffering. They should. But there should be no subterfuge about providing patients with abilities to end their own lives.
It's in the Israeli Knesset this week. I don't know if you read that.
Huh?
I don't know if you read that. It's in the Israeli Knesset this week. Some
No.
sort of bill that came up to have, I don't know if it's assisted suicide or you take your own life if you're dying. It's something in Israel. I'm not sure. One of those cases.
Well, there are parts of the world where it's
No,
done.
Israel came up. The Israeli Knesset came up this week.
In Belgium, I think you can, and I think in the Netherlands, actually, physicians will actually participate in physician-assisted
There's
suicide.
a lot of things in
Huh?
They do a lot of things there.
So, in general, most physicians are not comfortable with providing the means and/or being present in patients who wish to end their own lives. One other thing about end-of-life care that's important is the concept of futility. Now, futility, you would think if I went around the room, you'd pretty easy to define. Well, it turns out, was it Justice Holmes, one of the famous Supreme Court justices, when talking about pornography, he said, I can't define it, but I know when I see
Potter,
it.
I think it was.
I think futility is that way. I think most of us kind of know it when we see it, but it's probably very hard for us to define it. And that's because I think each one of us defines it very, very differently. And they're different kinds. So, for example, there's physiological futility. That is, if someone has had a cardiac arrest and they're dead, you can do whatever you want, they're not going to be made to life. So any activity you engage medically with that patient is absolutely futile. And so there are lots of kinds of definitions. And one thing is certain, that true futile care, families can't demand it at the end of life. And that's one of the hard ones because patients and their families are so emotionally involved in saving the life of their loved one. They demand care that is not appropriate because it's not going to work and it's just going to cause a lot of suffering. So that's one of the things you have to be thinking about, is not demanding care that's futile. Now, what's kind of a mechanism for end-of-life decision-making? Well, if the patient's out of capacity, that's easy. You just do what the patient asks you, and if you're not happy with that, you ask them to get another physician. You must stay with them until a new physician is provided. You can't abandon them, but neither can they compel you to render care or withhold care that you consider yourself personally to be morally objectionable. Now, if you have a patient who lacks capacity, how does one decide who one listens to? Well, ideally, if the patient has either written something, designated a surrogate specifically, what that patient says or what the surrogate says is what you need to do. And again, that's a good thing to do. It's one thing almost no one in this room has either done or wants to do. But to have a talk, should I have this, should I have that, here's what I want, here's what I don't want. In terms of what does one do when someone's at the end of life and no advance directive has been given, what do you do? In general, the order of doing for someone who's at the end of life, the first order is to do what they wish. If you don't know what they want, then you do what the people caring for the patient thinks is the best care for the patient. And that can include withholding care. And then finally, the most difficult part would be if you really feel you can't resolve this and there's conflict between the family in a way that it rises to a certain level, then you have to seek out court's guidance, which in general is a very bad way to do it. Because it takes a long time, it's driven by very clear-cut precedent and so on. There's a lot less room for the humane peace in that circumstance.
Nobody's happy.
And nobody's happy is right. Now, the most important thing I want to leave you with, and I hope this gives you a little flavor about what we face as physicians with end-of-life care decision-making, is the most important thing, which nobody wants to do, is go home tonight, get someone who's going to be taking care of you should that time come, and say, you know what, I'm thinking about it. I want this, I want this, I don't want this. If you have any other questions, ask so-and-so. But don't, how many times I've sat down with a patient and said, listen, there's a problem here, you're gonna have a big operation, you ought to talk. Nah, I don't wanna talk about it. If it comes up, they'll figure it out, I don't wanna talk about it. That puts your loved ones in an impossible situation. I don't wanna kill my mother. I don't wanna torture my mother. Well, the only way to know is to really talk about it in advance. So if we leave you with that idea, that the moral imperative here is to try to think about these things and talk about it in advance, you'll be doing yourself a big favor. Thank you.